All right, everyone. Well, thanks for coming out. It's the December M&M always makes me feel loved. So we'll get right into it. Per usual, same begging that I always start with. Please follow us on social media. Trinity Health of EMS of any of EMS on Facebook, TH of any EMS on Instagram. Couple slides I have to put in for the CME requirements. Announced this last time. Our new website, mercymedcon.org, is now live. If you scan the QR code, it'll take you right there, versus you could also just go to mercymedcon.org. I would ask you, if you have a moment right now, to go ahead and go there and then click the join button. That'll get you signed up for a email list so that we'll be able to send you email directly about educational opportunities throughout 2026. We're not going to spam you. I probably won't even send out stuff, once a quarter. Just a reminder of what's coming up. And new modules, stuff they're putting out on Prodigy for your education upkeep with everything. Also, if you want to see previous M&Ms, the M&M format this year has basically been, we kind of do a lecture in the beginning, and then we do cases to reinforce the concepts from the lecture. The lecture portion gets posted on YouTube. And so if you go to mercymedcon.org and you just click on the YouTube icon, it'll take you directly to the playlist that has all of the lectures in it. And then also, if you want to get to the Facebook and the Instagram pages, you can also email us by clicking that. That'll send you to mercyems@trinityhealthofany.org. So the other stuff that's available on here, different forms for if you dropped off a patient at Mercy and you want to get follow-up on them, you can just fill out that form electronically. It'll come to me and Renee, and we'll get back to you promptly with a patient follow-up. If you had an interesting case, one of the cases from tonight was submitted not via this form exactly, but was like an interesting case that someone had. And so that's how we can, other than finding them ourselves through going through the case stuff to build out the M&Ms, if you have one you learned something from or you thought was interesting, you can submit it to us there. If you're with National and you're going to be, National or Chapin, you're going to be filling out surveys for using Trauma Gel. The link to that is right there. And then the education schedule at the bottom, that'll get you all of our educational offerings for 2026. So all of the M&Ms are already posted. The registration is open for the whole year, as well as the other classes that we do in collaboration with ED nursing. So there's classes on if you're less comfortable with the drips you might have to titrate on an IFT, for example, you can come to one of the critical care medication classes that they offer that they do for new ER nurses and learn about the pumps and the medications and stuff that you would be using. Perfect. Yeah. So we've got those there. A couple other updates as you're dropping patients off at Mercy. Before, it used to be that only the charge nurse had EMS Pyxis access to refill your meds. Now all nurses have that access, so you can just ask whoever you're giving a report to or anyone to pull any of the non-controlled meds for you. Anything that's not in the NARC box, they can pull from the EMS Pyxis for you. And if you're calling for MedCon, don't bother going through CMed. You can call just directly one of those two numbers. Those are both recorded lines, so they meet the regulatory requirement in terms of the MedCon interaction being recorded, but you're cutting out the whole extra step of involving CMed, so you're going to save yourself a decent amount of time. So if you weren't familiar with, the big news, as of Monday, Mercy no longer has any labor and delivery services. So it would probably be in your best interest to avoid bringing any laboring patient to us. Obviously, EMTALA still applies, and if the patient is there, we're going to do our best to take care of them, stabilize them, and then transfer them out. But we do not have labor and delivery services any longer at Mercy as of Monday. All right, so we're going to jump straight into it. This M&M is all about EKGs. I'm kind of taking several of my shorter lectures that I put together and put together into one kind of mega learning experience. So the first one is getting better EKGs in terms of getting better quality or like a hospital quality EKG in the field. So there's three main parts to this. There's skin prep, managing the electrodes, or where you put the electrodes, and then managing the cables once they're attached. So talking about skin prep, every patient should get wiped with at least a washcloth. Everyone has some amount of oil and stuff on their skin that you're going to get some of that off to get a better contact with the skin with the electrode. And pretty much all men need to be shaved. So you should have a disposable razor or something else in your kit to be able to get down, to be able to shave them down for that. So I would wipe, shave, and then wipe again to get off the hairs. Now, assuming that you should not be pre-connecting your electrodes. The second that they come out of the packaging, they start to dry out. And they will degrade within minutes to hours of having contact with air outside of that environment of the packaging. So you really, you aren't saving a whole lot of time by having them clicked on in advance. So don't do that. Just pull them out, snap them on, and then put them directly onto the patient when it's nice and fresh, because the adhesive is usually still fine. It's actually the gel in the middle of the electrode that starts to dry out rapidly, and that's actually the part that makes the electrical contact. Now, in terms of placement, the big issues that people run into are putting the limb leads on the chest rather than on the limbs, and that the precordial leads or the chest leads, if they are off by as little as 2 millimeters, they can create or mask ST segment changes, which is like less than 1 rib space. So it's super important to get it in the right spot. So what do you see on this EKG? Anything that looks abnormal or even kind of like a normal variant at all? Okay. So we've got some ST elevation in V1, V2. Yeah. Okay, and we got that RSR prime pattern in V1, V2. So the only thing about this, so this is a completely normal 12 lead, except V1 and V2 were intentionally put too high to illustrate what happens when you put them in the wrong place. These are actually all the way up like on the collarbone, and then this is the same person with EKGs in the correct anatomic location. So you can see there the difference just in lead placement. That's the same person, the same actual patient. You just put them in the way up high versus in the correct positioning. So you can make a ton of unusual changes by not having your electrodes in the exact right spot. So as far as the limb leads go, everywhere from the insertion of the deltoid out and everywhere from the inguinal ligaments out is all fair game. From that point outward, everything is electrically the same. So obviously, part of the reason we end up putting the electrodes on the torso is because we get less artifact, right? So I try to get as close to those two kind of demarcation lines as possible. So, you know, you might put one here, and then you can put the blood pressure cuff right beneath it. And then sometimes just pulling down someone's pants just enough to get like to the hips, you can get an attachment there without a whole lot of artifact as well. So the precordial landmarks, they're bony landmarks that you need to palpate on the patient every single time. So what we're looking for is called the sternal angle, also called the angle of Louis. And it is where the manubrium turns into the sternum. So you've got jugular notch up here, and then manubrium attached to that, and then that angle where one turns into the other. Now, for some reason, it seems like in older men, it kind of seems to end up being like really prominent, almost like poking out. That's where that lump, if you feel that lump, that is the second rib joining the sternum. So you feel that, and then you come off to the side. So you feel that lump, and you come down and over. Now you're in the second interspace, third, fourth interspace is how you're finding your actual landmarks there. If you're having trouble finding the edge where that is actually occurring, the manubrium is 3 of the patient's fingers tall. So if you're having trouble finding it on yourself, you can take 3 fingers and then line it up with the jugular notch here, and then you'll find that angle right there. Okay, and then that's where the second rib is joining. So it's second, you feel that lump come down and over, and now you're in between ribs. So that's second interspace, third, fourth. Then your other lines that you're using to line this up, Remember, the clavicle comes all the way to the end of the shoulder, basically. So midclavicular usually ends up being further out than people give it credit for. And then also, we're looking at mid-axillary line, which is all the way in the middle of the armpit. A lot of times people are putting them too anteriorly because you're not actually coming all the way around to see how far back that is on the patient. So in terms of placement, we're going to start with V1. So here's that angle, the costosternal angle, or the angle of Louis. So that's where the second rib is. So you're going to feel that lump. So you're going to feel the lump, then come off the side, boom, we're in the second intercostal space, then feel down 3, feel down 4. So fourth intercostal space, right central border, that's where V1 goes. Then opposite side is where V2 goes. Then which one are we going to do next? V4, exactly. So we're going to feel fifth interspace and come over to midclavicular line. Then which one? 3. 3 goes halfway between 2 and 4, exactly. Now, 6, we're going to follow where we felt, we're going to feel where we felt V4. If you're online, please make sure your microphone's muted. And we're basically going to take that at a horizontal line, 90 degrees to the sternum, around. So don't try and follow the rib space going up. You're just going to follow almost like it's coordinates, right? So we had V4 and then here's the line that it's at, and it's just coming across as a straight line. And so you're going to come around to midclavicular line, or excuse me, to mid-axillary line. That's going to be where V6 goes, probably further back than you thought. And then V5 is either halfway between 4 and 6 as a shortcut for if you're having trouble finding the actual anteroaxillary line, which is front of armpit rather than middle of armpit. So you should have V1, 2, find 4, 3, and then 4, 5, and 6 should essentially be in a horizontal line going straight around the chest. Don't try and follow the rib space up or down. If we need to do posterior leads, we're going to extend that 4, 5, 6 line. We're going to extend it, just continuing around at that exact same horizontal level, except our landmarks here are the each edge, the lateral, the middle, and then the medial edge of the scapula for 7, 8, 9. And if we're going to do right-sided, it's just mirror image on the other side. So let's talk about what to do with breast tissue. So this is taken from a paper where they thought that this woman with chest pain was having a STEMI, and then they repeated the EKG and the STEMI went away. And this was a demonstration of a patient with macromastia, very large breasts, causing displacement of the electrodes enough that it was creating and then masking ST segment changes. So what happens? So normally when you place 12 leads, what do you do with breast tissue? Yeah, people lift it up and they put the stickers on, and maybe that's the correct space, but then what's the next thing you do? You let go, right? So even if it was in the right space, it's not anymore, okay? Because we let that soft tissue drop back down. So my recommendation, and the recommendation from the authors in this article, is rather than lifting the breast up to go underneath the breast, that you find the correct anatomic location, you go just directly on top of the breast. So their eloquent point that they say in this: breast tissues are fake friends and definitely not a good point of reference. Another study where they were looking at women and their experience getting 12 leads with EKG placement underneath the breast tissue versus on the breast tissue. Women preferred electrode placement on the breast rather than under, as this method required less manipulation and felt less intrusive to the participants. So not only are we putting it in the correct anatomic position and it's staying there, but it's also less invasive and less intrusive on the patient. So this is the way that I was taught to do 12 leads when I was an EKG tech. And this is the way that I recommend that people do 12 leads. I probably am blowing some of your minds right now, but definitely on the breast rather than lifting and going underneath. You'll get better quality as well. So when it comes to your cables, I call it the blob or the box. I'm sure it has a more technical name. but you all know which part I'm talking about, right? On the cable. All of the artifact that gets induced from any movement of the cable occurs between the patient and that blob. Everything proximal to that doesn't induce any artifact, right? You could be playing jump rope with this part of the cable and it would not cause any artifact to be created on the EKG. It's only this part, the individual wires coming out of here that are causing artifact. So you need to move that to be on the patient ideally. Probably don't have this anymore, but when these come brand new, there's actually a clip on the back of it to be able to clip it to the patient. I'm sure within the first 10 uses, someone goes, what the hell is this for? And snaps it off. But it is designed to be on the patient to minimize that movement. So your 4 main things in terms of getting a better quality or a hospital quality EKG in the field are always prep the skin, even if it's just wiping them down with a washcloth. Don't pre-connect your electrodes. Always palpate the bony landmarks like we talked about on the rib cage, and then move the blob or the box to the patient so that it's sitting directly on them with them. So they're all moving together. Now, this looks like a reasonable quality EKG. I've certainly seen worse EKGs that were done in the field, yeah. So this was obtained on a patient that was walking at a treadmill going 2.5 miles an hour at a 12% incline. So using those techniques, this is from an EKG stress test. So using the techniques that I just told you, you can get EKGs like this even while someone's walking on a treadmill. So imagine what you can get when someone's just laying on a stretcher. Okay, there's no reason you can't. There's no technical reason that you can't get a quote unquote hospital quality 12 lead in the field by doing the stuff that I've mentioned. Questions about that? You look very skeptical.
Yes. So EKG electrodes coming out of packages. Zoll, I believe, is the only one that packages them in the appropriate numbered.
Mm-hmm. Otherwise, you're buying the bulk bag.
Correct.
Yeah.
So 99% of the folks here are taking them out of a package that's open.
Yeah. So
and then there's the whole wet electrode, dry electrode. I know Zoll, professes that theirs are the best wet gel electrodes of the planet.
Yep.
And everybody else is a dry gel and they suck.
Mm-hmm.
And they charge like.
Yeah. So if you're just grabbing them out of the bulk bag and it comes in, 100 or whatever, then do your best to keep the bag, rolled up and sealed up. I don't know, we used to, when we had those, we would put them like in a Ziploc and try to keep it sealed the best we can. But don't just leave it open to air with stuff pre-connected, the wires into it. Like just take them out when you're going to use them and then do your best to try and keep it as sealed as you can. It's the best that you can do.
And then the third thing is dealing with breast tissue.
Yes.
If it's the point where the breast tissue is becoming an issue, I can envision trying to find landmarks far more difficult coming from outside the breast tissue than underneath the breast tissue.
So, but here's the thing though, if those landmarks, they're always going to be deep to where the breast is. So if you're going to get it in the right spot, that means you have lifted the breast to get them in the right location. And now if you're going to keep it in the right location, you're committed to holding the breast up, or you're letting go of the soft tissue and you know that they are no longer in the correct anatomic position.
So basically
no, if you go on top, it's still going to be in the correct location. Yes. But you're palpating on the sternum, and then from here I'm going in a straight horizontal line out and across. You're not necessarily lifting up and manipulating the tissue directly. Other questions? Those are very good, valid questions. All right, so let's move on to some of the EKG reading stuff. So we're going to talk about 4 things in terms of reading EKGs. So first we were getting better EKGs, now we're reading EKGs better. So we're going to talk about the timing, measuring ST segment changes, what contiguous leads are, and what reciprocal changes are. So in terms of timing, so we got ST elevation here, right? In the inferior leads with reciprocal changes, right? Like this is, if patient's having chest pain, this is bad, this is STEMI, okay? So look at the timestamp here. This is 11:17. And then 4 minutes later, everything's completely gone. What do you think happened in between? Okay. Assuming nothing, yeah, assuming it's still this, assuming this is not an equipment problem. Okay, this is something anatomic, physiologic happening. What do you often give patients when they're having chest pain? Nitro. That's exactly what happened. So they gave this person nitro, and their chest pain got better, and then the ST segment changes went away. So if you were not on top of your game and you gave that patient the nitro and got rid of their chest pain before you got the EKG, you're not going to have any idea what it was beforehand. So in this study, they looked at ST elevation and getting nitro in the field, and the ST elevation resolved in between 35 and 85% of cases, which is, it sounds like a uselessly large interval. It's like anywhere between sometimes and always, right? So, but it was a decent amount of the time, okay? And the patients where the ST elevation goes away, the blockages that they had in their arteries were just as bad, but their treatment got delayed, which makes sense because you get them to the hospital and they're like, what are you talking about? Got better. I don't have to do anything. You fixed them. But they still had just as bad of a blockage. So their treatment in terms of getting to the cath lab ended up being delayed. So the lesson here is get the EKG early and prior to giving any medications for the treatment, ideally with the first set of vital signs. So get it with the first set of vital signs. Must go faster, okay? Another study, they had medics get 3 EKGs, one at the patient bedside with the first set of vital signs, one as the patient got loaded, just as you're kind of like loaded, like about ready to go, and then one as you're basically backing into the ED. And so they found about 85% of STEMIs in the first EKG, 94% by the second EKG, and they caught 100% by the time they did the third one. So you can catch about 15% more EKGs or more STEMIs by doing those serial EKGs. So I want you to think of the EKG as another vital sign that, particularly for any kind of chest pain, but any other kind of cardiac patient, should be reassessed. And I would say at minimum, you're doing 3. So on scene at patient side with your first set of vital signs, 1 en route, and then 1 as you're like pulling into the ER. So let's talk about measuring ST segment changes. How are y'all taught to measure ST segment changes? Mm-hmm. Are you measuring it? Are you measuring it compared to the TP segment or the PR segment? TP segment, okay. And is it right at the J point or is it past it by some amount? Okay, so good. There is actually a international published standard between like the AHA and a bunch of different organizations on how you're supposed to measure this. And the reason I mention it, because if you look in different textbooks, different research, sometimes you'll see 40 or 60 milliseconds after the J point comparing to the TP segment versus the PR segment. You'll see different things different places, right? That's the great thing about standards, is that there's so many to pick from. So we're looking at the J point, which is where the S wave turns into this segment before it becomes the T wave. And we're going to compare the J point there, that one point in space, to the TP segment, which is the line between the T wave and then the next P wave. That's the true isoelectric line. So here, how many millimeters of elevation are you estimating? I hear 3.5. What did I call it? 3. Yep. Close. Good. How about this one? So here 2.5, here 4, call it 3. This one's a little more challenging. What did you say? Sure it does. Paste counts. So I'm calling that one 2.5, mostly because I'm saying that the T wave is probably ending about like here. Because that one, right, like that's hard to kind of pick a spot where the T wave is really. I'm picking right there because to me this all looks like T wave, and now if I'm going to pick one spot where it kind of transitions, it's roughly right there. Up here. Yeah, I'm not sure. That's where I would measure it from. But you are talking about like about a millimeter's worth of difference between there because this is like really blown up. How about that one? Probably a little bit easier. Yeah, 1.5, 2. Once we're getting into the halves of millimeters, that's good. Okay. Just a couple more. What are you estimating here in terms of depression? One and a half. Okay. How about this one? So remember, our J point is going to be like here compared to our TP segment. So that's more like 2. Hmm? Yeah.
It looks like
You're talking about here?
as you continue to the right.
Yeah, the TP segment is downsloping a little bit here. So I kind of picked the middle of where it's downsloping here. But you will see sometimes a downsloping in the TP segment. It's called spotting sign, which is actually more diagnostic of pericarditis. But how about here? Last one. Yeah, 2, 2.5. If we're within a half millimeter of each other, I'm happy. Okay, good. So let's talk about what contiguous leads are. So first of all, how do we get an EKG like this? So what the machine is actually doing is it is recording all 12 leads for the entire 10 seconds, and then it's building this representation for you. And it does it like this. So it shows you, so this is each of these is a rhythm strip essentially of each of the 12 leads for the full 10 seconds that the EKG gets recorded. So what it does is it shows you 1, 2, and 3 for 2.5 seconds. It shows you R, L, and F for 2.5 seconds. Then it shows you V1 through 3 for 2.5 seconds. And then it shows you V4 through 6 for the last 2.5 seconds. And that's how it builds this. That's how it builds this display, this printout of everything. Which means that, if you didn't know this already, every QRS that lines up vertically is the same QRS, but just from 3 different perspectives. Okay? Now, this is how the EKG leads lay out on the actual anatomic position of the heart. And so when we say contiguous leads, it's because they're looking at similar parts of the heart. So you've got 2, 3, and AVF that are all looking at the inferior wall. You've got 1 and AVL, V5, V6 that are all looking at the lateral wall. And then you have V1 through V4 that are basically looking at the anterior and the septal. Okay. So when we talk about contiguous leads, it's because they are next to each other in terms of how they're looking at the heart spatially. So when we're talking about definition of the STEMI, which is and so another thing in terms of our ST elevation cutoffs and STEMI definitions, there are a bunch of different definitions for STEMI in terms of millimeter cutoff criteria that vary both with gender and with age. What's probably the generic one that you've had pounded into your head? 2 or more millimeters and 2 or more contiguous leads. Exactly. And so the reason that we want to look for multiple contiguous leads is because if there's something going on in the inferior wall of the heart, if we have 3 different leads that are looking at the inferior wall, we should hopefully be able to get multiple witnesses. Does that make sense? Okay. So this is how, when we take this, and if we color code the ones that are in similar anatomic regions, and then once it's laid out onto the paper, this is what it looks like. So you've got the inferior leads, which are all anatomically contiguous, then 1 and L and 5 and 6 that are anatomically contiguous. And then 1, 2, 3, and 4, honestly, because these are sort of like evenly spaced out, I would argue that maybe 2 and 3 are, and that 4 and 5 are, because this is really, it's kind of just taking snapshots going around the heart this way. So I would argue that if you have ST segment changes in 2 and 3, I would still call those contiguous, but it does kind of depend on what the big picture looks like. Okay, but this is how our contiguous leads get laid out on the actual paper. So reciprocal changes. What were you taught reciprocal changes are? Yeah. Good. Yeah, you have the depression moving opposite the elevation. So generally how this is taught is that if you have, it's between 2-3 AVF and anywhere else. But what I want you to think about more is actually 2-3 AVF and 1 in AVL. And the reason for that is because they are at pretty much 90-degree angles to each other. So their reciprocal relationship is electrically perfect. So you can really see some subtle findings sometimes. So this is not subtle, but so we've got elevation in 1 AVL and depression 2-3 in AVF, right? Seals the deal. This one, also, we've got depression in 3 in AVF, maybe not so much in 2, but we still have clear-cut depression in 1 in AVL, okay? Clear-cut. Now this one, getting even a little bit more subtle. What jumps out to your eye most on the CKG? Is it this ST elevation or is it this depression? The depression, okay? So what I want you to do is anytime, so here we're seeing an abnormality in 2-3 in AVF. So I want you to immediately then go to 1 in AVL. So if this is what jumps out to you the most, we see depression, which means we're going to look for what in 1 in AVL? Elevation, right? And we can jump there, and if we start looking for it, what do we see? We see it elevated immediately. So we'll go through more examples of this as we go through the rest of this part of the M&M. But when you see an abnormality in 2-3 in AVF, look for the opposite in 1 in AVL. Or if you see the abnormality in 1 in AVL, look for the reciprocal change in 2-3 in AVF. So to summarize this part, get your first EKG with your first set of vital signs. Repeat EKGs are king. You're going to measure your ST from the TP segment. Continuous leads are called so because they look at the same anatomic area of the heart, and reciprocal changes are between 2-3 AVF and pretty much 1 in AVL. And they're really going to clench your diagnosis for when you're having, if you have reciprocal changes, that this is in fact a STEMI. So we'll move on and now talk about some patterns that don't meet STEMI criteria, but still need to go to the cath lab. Here are N STEMIs that need the cath lab. So either you have an occlusion in your coronary artery or you don't. And either it meets STEMI criteria or it doesn't, okay? And STEMI or STEMI. So a type 1 MI, that's your classic, right? That's your classic thrombus that ruptures, and you have the platelet aggregation, turns into a clot. That's type 1 MI. That's the classic one that we're taught about, is a clot that forms because of, plaque rupture, okay? Now, no occlusion. So if you have, the other part of this is we're defining MI as meaning you have a rise and fall in troponin, which indicates heart muscle damage, okay? So if you have no occlusion, but you have a rise and fall in troponin, what are some reasons that might be happening? And there's no problem in the coronary arteries. Okay, pericarditis. Exactly, general strain, more so, right? So someone is really septic and really sick. They could be having enough strain on the heart that they're going to have a rise and fall in troponin, even though the coronaries are wide open. I've seen a patient with severe enough GI bleed that they did not have a coronary occlusion, but they had an NSTEMI because they bled out all their blood through their butt and then were severely anemic, and then the heart muscle couldn't get enough blood. So it started releasing troponin because it was getting damaged, okay? So this is basically the heart getting overexerted, even though there's not a blockage in the fuel line, okay? So, sometimes we see ST elevation and there's not an occlusion. What are some things that can cause ST elevation where there is not a problem with one of the coronary arteries? These are normal variant things you see all the time. All the mimics, right? LVH, bundle branch block, pacemaker, all that stuff, okay? So those would meet STEMI criteria, right, in terms of ST elevation, in millimeters and such, but there's no occlusion, okay? That would be a false positive. So this is what we're talking about, is patients that have an occlusion, but they don't meet STEMI criteria in terms of millimeters. Now, we've talked about STEMI versus NSTEMI for a long time, but that terminology is starting to kind of fall out of favor. And in that paradigm, STEMI meant you're going to the cath lab, and NSTEMI meant maybe you go to the cath lab later, we probably just heparinize you, I don't really know. But there were patients that had coronary occlusions that would benefit from going to the cath lab that weren't going to the cath lab, okay? So now we are moving into this era of looking at OMI versus NOMI, which is occlusion MI versus non-occlusion MI, right? So the idea is we have STEMIs, which are usually OMIs, right? That they have a blocked coronary artery, but we have other things that indicate a blocked coronary artery that don't meet the traditional STEMI criteria. And so the idea is let's try and create a definition so that all the patients that need to go to the cath lab will go to the cath lab urgently. Whereas your person that's having, diffuse ischemia because they're super anemic and super septic, well, they don't need to go to the cath lab. They don't have a blocked artery, right? And that would fall under NOMI, or non-occlusion MI. So the 5 patterns that I'm going to talk about are an isolated posterior MI, high lateral MI, De Winter's T waves, a left bundle or paced rhythm having a STEMI, and then hyperacute T waves. So talking first about an isolated posterior MI. These are easy to miss because we're not seeing anything going on in the limb leads. We're only seeing it going on in the precordial leads, right? So one of the things we talk about, when you're only seeing ST depression like this, what are some causes that you're thinking of? Posterior MI, good. On the slide, like it. Anything else? Okay, posterior leads, good. Sometimes if you have anterior ST segment depression, it's not necessarily posterior MI, it's anterior ischemia, right? And so the way that we differentiate that, so like left main insufficiency would be, or left main occlusion would be what people are worried about. So in a posterior MI, you'll start to get tall R waves. And the reason for that is your R waves from the front are actually Q waves from the back. So you're starting to develop Q waves posteriorly, but they're becoming R waves anteriorly. So you can have these early tall R waves, as well as ST depression that is maximal in sort of like V2 to V4 territory, versus left main insufficiency, where the ST depression is maximum in V5, V6. And that's how you differentiate between the two of them. Like you said, we're going to get posterior leads, and we're going to use a different cutoff. We're going to use the 0.5 millimeter cutoff. That's 94% sensitive, 100% specific for diagnosing a posterior MI. If you increase that to 1 millimeter, you're only 50% sensitive, which means you're missing half of the true heart attacks by using that higher cutoff. So it is a 0.5 millimeter rather than using 1 millimeter. Now, the part that's super unfair is between 22 and 39% will have no ST depression V1 through V3 when you do the anterior EKG. They would only have 2 depression, they would only have elevation if you do the posterior EKG. So you have to be kind of really alert to what you think is actually going on with the patient. And if you were like, man, this guy was sweaty and he vomited and this was exertional and it's radiating to his jaw and left arm, and he says, oh my gosh, this feels just like my last stent. And you're like, oh, EKG looks fine though. Maybe let's do some more investigating, okay? So put more stickers on patient, get more EKGs, serial EKGs, maybe a posterior if you think that could be what's going on. So this is the other thing. Who is that? What is that? You sure? Right. It's not. The eyes and mouth are all screwed up. You need to recognize that because you were relying on pattern recognition in an orientations you were unfamiliar with. So we can use this to our advantage because your brain is probably not primed to recognize ST depression exactly the same way that it is primed to recognize ST elevation. So what we're going to do is we're going to take our EKG and we're going to simulate flipping it over this way. So we're looking at the back of it and holding it up to the light. And so what that's going to do is, I start someone go, ugh, right? So suddenly those ST segment changes look a lot more prominent. And that's because your brain is much more primed to look for elevation than it is for depression. So now that you see this, what are you thinking? What's that? Well, yeah, but we're on the back. So we've noticed some pretty significant ST depression. So what next step might you want to take with your patient here? Posterior EKG would be an excellent idea. Good. So next pattern, high lateral MI. These are easily missed because of basically the vectors and the specific angles involved of where the coronary artery is. What is the most prominent abnormality that you notice on this EKG? Okay, lead 3 depression, probably also maybe AVF, a little bit. So if you see an abnormality in 3 and AVF, what should you immediately look for? Look in 1 and AVL. So really scrutinize 1 and AVL. Do you see any ST elevation there? Maybe like 1 millimeter, but that's enough to clinch the diagnosis if you have a reciprocal change, okay? And this is why these are often missed, is because the most prominent feature is the depression. And people see the depression, they go, oh, it's just ischemia. And they don't look for the reciprocal change. And then there's actually elevation there that clinches the diagnosis. So again, that relationship between 2-3 AVF and 1 in AVL is key. So like we've said, if you see any ST depression in the inferior leads, look for elevation in 1 in AVL. And likewise, if you see ST depression in 1 in AVL, really scrutinize the inferior leads for any amount of ST elevation. So this is a patient that actually ended up having an inferior MI. It was missed initially. Same with this one. Well, this was a high lateral. But you recognize this, and then this, a little bit of elevation was not recognized. So De Winter's T waves. Now I know none of you are looking at this and going, looks fine. Right? That's good. But you might go, that looks really weird, but I don't know if I should call this in as a STEMI. You should. Okay, this is De Winter's T waves. And the characteristics here are a large hyperacute T wave, or as I call them, big ass T waves, with ST segment depression. Now, when this pattern was originally described, De Winter, they thought that it accounted for about 2% of all LED occlusions, and that the pattern stayed, the reason that this was often missed was because the pattern stayed the same until the artery got opened. What we've learned since then is that you can have the De Winter pattern turn into an obvious looking anterior STEMI. You can have an obviously looking anterior STEMI turn into De Winter and kind of back and forth. So it's a little more dynamic than we originally thought it was. But see, look in here, you got those big T waves with ST depression. The one that kind of looks the most classic is like this lead and this lead, V4 and 5. Those are diagnostic of STEMI. This patient needs to go immediately to the cath lab. Yep, so there's some inversions in there. I'm not sure if it's actually depressed, but if you think there is inversion or depression, where should you be looking? One on AVL. That I don't know that there's an ST segment change, but that T wave looks disproportionately large to me. So that would be a hyperacute T wave that would also kind of add to the evidence here. Now this guy, this is the repeat EKG on him. So you can see the De Winter pattern turning into that obvious anterior MI. Okay. So STEMI with a left bundle. How many of you can? So first of all, can we diagnose a STEMI in a left bundle or in a paced rhythm? Yes, we can. How? Scarbosa criteria. That's right. So normally, this is, I probably, when I say Scarbosa criteria, I can feel your brain. I can feel your eyes rolling back in your head, and you can feel the smooth brain sitting in because it's like discordant, con, up, down, cordant, right? Right. Is this or is this not a STEMI? So this is normal left bundle branch block, okay? Now, left bundle branch block normally, mostly down means J point should be on the other side of the isoelectric line, okay? So this is mostly down, which means J point should be up. This one, this is like V1, and then by the time we get to V6, we're mostly up, so J point should be down on the opposite side of the line. This is normal, okay? Which is called appropriate discordance, but ignore that. We're not going to get into the discordance concordance. Okay, now, mostly down, J point also down, bad. Oops. Okay, mostly up, J point also up, bad. So don't worry about discordant concordant. Just know that for really any bundle branch block, left or right, the last part of that bundle, which in the left bundle is all of it, if it's negative, then that J point should be on the opposite side. If that J point is on the same side, that's abnormal. That's an ischemic change. Is that hopefully more straightforward than when you were taught this the first time? I'm seeing a couple nods. Okay. So the other part of the Scarbosa criteria, the original Scarbosa criteria is, okay, so this is QRS down, J point up, but if it's more than 5 millimeters, that's too much of a good thing or too much of an expected thing. So that would also be abnormal. But what we found is that this 5 millimeter cutoff was not so great. So a guy named Steve Smith, who is an absolute EKG savant that works in Hennepin County in Minnesota, came up with the idea that it's not just 5 millimeters, it's proportional to the whole size of the QRS. So if it's more than a third of the depth of the whole thing, then that's too much. So the idea being like here, this thing is, here, we'll use this one because it's easier. So this is 10 millimeters tall, which means that this part should not be more than 3 millimeters deep. If it's more than that, that's too much. Same thing going the other way. But it's a little bit harder to remember than just the 5 because that's one big box. But so not only is it QRS down, J point should be up, but it's also if QRS down, J point up by too much, that's called excessive discordance. That's where this comes in, if it's proportionally too high. All right, and our last pattern, hyperacute T waves. Right, those just look really big and abnormal, right? Kind of regardless of what you're measuring, the J point, the ST elevation. Those are enormous T waves, and they do not in any way look normal. What else can have really big T waves other than ischemia? Hyperkalemia, exactly. So here we've got hyperkalemic T waves, and here we have ischemic T waves. Now, our hyperkalemic T waves, if you cut them in half, they look symmetric. If you cut the hyperacute T waves in half, they tend to be asymmetric. These, if you extend this curve, they kind of make a frowny, they kind of make a smiley face up, even though there's nothing happy about hyperkalemia. It's still better than if you're extending the curve this way, you're making your frowny face down, sometimes called tombstoning. or the concave down for your ischemic T waves. So those are the 5 patterns. Isolated posterior MI, high lateral, De Winter, left bundle / paste. The Scarbosa criteria also work for paste rhythms, and hyperacute T waves. So summarizing everything we've talked about, if you've got ST depression and a tall R wave, think about posterior MI. You can flip the EKG over to draw your eye more to ST depression that maybe wasn't as, maybe there's ST depression that didn't jump out at you when you do it this way. Now it's going to jump out at you and you can kind of go, oh, maybe I should do a posterior EKG, or I'm recognizing something else going on. Remember the relationship between 2-3 AVF and 1 in AVL. If you're noticing changes in one grouping, look in the other. ST depression plus a big T wave is De Winter's, which is an MI. Left bundle branch plus ST elevation that's more than 1/3 of the depth of the whole thing. So if it's more than 1/3 of the height of the QRS complex, that's too much of a normal thing. As well as the other changes that we talked about same side, opposite side. And then your frowny face or your asymmetric T waves, those are MI rather than hyperkalemia. All right, so let's all take a well-deserved break.